Good afternoon. After this amazing presentation by Francesco Maisano, I will try to allude a little bit more into some of the practical aspects and also some key updates of the transcatheter mitral replacement. Francesco touched upon the technologies a little bit, some of the progress that we have seen and some of the limitations. So we've seen that TEER is the dominant therapy when it comes to transcatheter therapy with huge evidence base and a very impressive upgrade in the recent European guidelines. But there are these patients that we have discussed before, the red light patients, that it's very difficult to treat, short, non-existent posterior leaflet, calcium, small areas. All these issues are very difficult to treat with TEER. And we do know that transcatheter replacement works. We saw a case from Onassis Heart of a valve in ring case recently. Valve in valve is now quite validated, balloon expandable TAVI into a previously surgically replaced bioprosthesis in the mitral space. Also, if you have a complete rigid ring, you may need to modify the anterior leaflet like we did in this case, but you may not. And of course, you have the valve in MAC, which is a different animal. Here, a case with Batman that was successful, but nevertheless, we do know that the concept exists. If you go transeptal, transfemoral, and you replace the mitral valve percutaneously, in any of these situations, you may have decent results, ranging from excellent valve in valve result to less than excellent valve in MAC results, but still, the concept of replacing and eliminating the mitral regurgitation is there. But what happens to the devices that we have been trying as a community? The engineers have been trying to develop over the previous years, starting the journey many years back, almost 20 years ago, 15 to 20 years ago. And most of these devices are no longer present. And the reason is that we have really hit a dead end due to various problems, the incorrect clinical assumptions, the inability to actually put patients into the clinical trials, technology roadblocks. I mean, the access being one of them, transapical versus transeptal. Nevertheless, a few devices survived from this era, the 12 that became Intrepid, the 10 died, which we thought it would be eliminated, but still around in the high lab recently had CE mark. And we moved to the newer generation devices now. The Intrepid is still there, the Alta valve, and we have devices like the InnoValve and other devices that are there and at an early stage, looking forward to these results. Why has it been so difficult? What is the problem? First, we have some issues that are related to the anatomy itself. The size of the mitral valve is bigger than the TAVI. The presence of calcium. The Achilles heel, I put it at the top, is the LVOT, the potential to obstruct the LVOT, and it's still an issue with any of these devices. But let's keep in mind the clinical condition of the patient. Some of these patients are really sick, and whatever you do to them, you're not going to make them any better. And I'm having a phenotype in my mind, the MAC female patient with severe MR or moderate MR, moderate MS, that you have a small ventricle and it's very difficult to treat, whatever you do. But let's not forget that the advent of TEER and the progression with the new iteration of the devices and the global expertise has actually by itself been a competition to the replacement technology. Now we're becoming bolder and we're able to achieve better results in this population. Nevertheless, the screen failure rates have been in the order of 80 to 90%. And I think this is an honest percentage because if you look at most of these trials, you see a screen failure rate between 50 and 60%, but actually there is a pre-screening process that we should acknowledge. And most of the patients with the mitral regurgitation that go through the process of getting into the clinical trials for replacement actually have been pre-screened, and the patients that actually take the screening follow after this initial screening. Having said that, over the last year, we have seen some significant progress. We have seen the Encircle trial presented by David Daniels and published, and also Paul Saraja presented the MAC arm of the SAMI trial. The first is the transfemoral transeptal replacement with M3, the Edwards valve, that showed this impressive 0.7% all-cause death at 30 days and 13.9 at 1 year. with heart failure hospitalization rates being very low. And clearly that has been a very good outcome. But also the transapical, and we have all been seeing transapical approaches, the Achilles heel of any technology, but still the tendine in the MAC arm, which is a very difficult population, showed a very respected 21% all-cause mortality at 1 year with heart failure hospitalization rates at 30.1. Both of them got approval by the FDA as single-arm studies, but single-arm design has been accepted by the FDA, and the other two trials in the pivotal, the other two devices, the pivotal trials, the tendine and the alta valve, follow the same pattern. But also we had the opportunity to present the early feasibility outcomes from the alta valve EFS that showed in the transfemoral cohort a very impressive 0% major adverse event rate in this transeptal novel device that I will allude to in a little bit. So Abbott had an FDA for the MAC indication, Edwards had an FDA for all comers, and also CE mark that has been there a few months before. And we recently had the Highlight, which is again a dual stage dock and implant concept similar to M3, but with a retrograde transaortic approach, had a CE mark, which is an important milestone. Also, the opportunity to implant this device commercially in Europe, it's available, has been available over the last few months. A few words about MAC. MAC is definitely the Achilles heel for everything, surgery, TEER, but maybe, and I say maybe, for the replacement is not as bad news. Most of the devices that are either being investigated or are now commercially available actually can treat MAC. And the interaction between the dual frame devices and the MAC is there. Of course, the MAC patients by themselves have got individual clinical issues. Most of them are in severe advanced heart failure, they've got preserved LVs, small LVOTs, and also many comorbidities. So by definition is a cohort of patients which are elderly patients with comorbidities, and the outcomes generally are not very good. But the advent of devices such as alta valve here, which is supraannular with a soft frame that interacts favorably with the mitral annulus, even in the presence of MAC, and moves away from the septum, has actually created opportunities in that field. And maybe that's the answer, or maybe one of the answers to the problem. So I will just elaborate a little bit on this device. This is a single stage transfemoral transeptal device. You use a 29 French steerable guide catheter, steerable sheath, and through that the delivery system. The valve is deployed from the mitral annulus all the way by unsheathing up to the roof of the left atrium. At one stage, the valve is repositionable, recapturable, and it can be removable even from the patient, but it can be repositioned up to the last stage of deployment before the deployment of the valve. Here's how it works. Usually you do a transeptal puncture with a balloon septostome. 8 millimeters of a balloon is enough. You flex the system down to the mitral annulus guided by echo and fluoro. This is on a functional patient with not a lot of calcium. You deploy the valve. It's not as fast as this, is fast forward, but clearly it can be deployed within 8 and 10 to 10 minutes device time, up to 15 minutes. Once you deploy the cage, you get engagement to the lateral and the medial wall of the left atrium, all the way to the rooftop. The valve self-centers, is nitinol, and it's functional even from the first stage. So patients usually are hemodynamically stable. And once you're happy with the position and the outcome, you deploy the valve. And this is how it looks on echo. It's a supraannular prosthesis, atrially fixated. Usually you get this elimination, but this anterior tilt of the valve that comes parallel to the axis of the LVOT maybe is the secret, alongside with the movement of the valve away from the ventricular septum. And this is how it looks on 3D from the atrial end. And also from the ventricular end on the left side, you can see the active sealing that the native mitral leaflets provide to mitigate PVL alongside with the skirt. And this is how it looks on TTE on this patient with functional mitral regurgitation with short posterior leaflet that was not deemed suitable for TEER. Recently, as part of the trial, we performed the first mitral stenosis procedure for this patient. This is a MAC patient with severe MS, previously operated for bypass surgery, 72-year-old, high risk. You can see mean gradient 11, mitral area of 0.5, MAC, not rheumatic. You can see the distribution of MAC severe, MAC volume over 2,000 to 2,500. You can see the spikes that actually move towards the center of the mitral plane, incorporating the anterior leaflet. Pulmonary hypertension, all of it, of course, post-capillary. Maintained cardiac index suitable for an 80 by 85, 40 millimeter. Severe pulmonary hypertension on induction, some noradrenaline that was given for the patient to maintain the systemic blood pressure, elevated the PA pressure to 113. After some milligram PA pressure went to 77. We elected to perform a 26 millimeter balloon using a VAX3 balloon, normal balloon that we use for aortic valve implantation at rapid pacing. We had some worsening of the mitral regurgitation, but not severely so. But the PA pressure responded immediately, and that was quite impressive. Would go down to 52, 54 systolic. Then the deployment of the alto valve was actually quite straightforward, because you engage to the calcium that maintains stability throughout the implantation that usually takes no longer than 10 minutes. And we were able to have a good position with good acute hemodynamic outcome. You can see just a trace of PVL initially, reduction of the, of course, mitral gradient immediately after the procedure, and an additional drop of the PA pressure below 50 immediately after the procedure. So now the Atlas trial is ongoing, having a MAC arm up to 100 patients and a primary cohort up to 350 patients. I can tell you 45 patients from the MAC arm have already been recruited, and the recruitment is very fast. And hopefully MAC will finish by the end of this year. Primary cohort, of course, will still have to go. I'm very privileged to be part of the PI and still top recruiter in our center. But of course, the guys from the US are catching up, and from Europe. So as generally, the conclusion is clearly the MTR is the gold standard, as Francesco alluded to before, but TMVR is becoming now a reality. I think we can see some light at the end of the tunnel. We have already three devices in Europe, two devices approved in the US, one transapical, one transeptal. And of course, two more are coming as part of the pivotal trials that are ongoing. So hopefully we will have an integrated toolbox to incorporate replacement as part of our clinical practice soon. Of course, another milestone will be a potential randomized comparison between replacement and repair. Of course, this is, in my humble opinion, not still a topic of discussion. Toolbox approach is obviously the choice here, but it will be very interesting to see the elimination of the mitral regurgitation by a reliable, reproducible, and globally, broadly applicable replacement device will become a new gold standard versus TR in a future randomized trial. Thank you very much for your attention. I'm happy to take questions.
Thank you, Vlas. Excellent talk. A lot of information to unpack there. So this is the first time that I see that you have severe MS and still you managed to use the alta valve, which supposedly it's a contraindication, right? So it was not included in the study, or not? It's moderate.
Absolutely. So we decided to incorporate one patient as part of the study. The MAC was there. Anatomical suitability was there, but we decided to go ahead and perform one procedure as part of the study. Then Columbia, Sushil Kodali and Rebecca Hunt followed with another case. And now, as far as I know, there are 4 more cases that have been implanted successfully in the US as part of the pivotal study. So the pivotal study has expanded the indication to incorporate severe MS as part of the MAC cohort, but only for 20 patients, no more than 20 patients, because we still need to maintain the indication of MR and moderate MS that was there from the beginning. But it's important because, as Francesco Maisano mentioned before, really the true Achilles heel of any percutaneous therapy is the mitral stenosis, especially with MAC. It's impossible to get a reliable result from any of the other methods. Even valve in MAC doesn't really work very well. And having a dedicated device for that may be a solution, but we still need to see the outcomes.
Yes, and this is there are no other solutions other than that. And Kostas Spargias will present, suppose, M3 data later and cases. But yes, this is something that we cannot tackle adequately. Do you foresee that down the line, if this study is successful and other devices come into play with sufficient data, do you foresee that at the end of the line, sometimes we will have a TAVI kind of approach when we deal with mitral disease?
I don't think so. I'm being pessimistic. Maybe it will happen, but right now, I don't think you'll have one device that will fit everything. It's a very, very difficult population. It's a very difficult anatomy. The anchoring is difficult and different. You've got two-stage dock and replace devices. You've got single-stage devices, atrial fixated, annular fixated, leaflet fixated. I don't know. I don't think mitral valve can ever be as simplistic as that by just having a TAVI approach. One size fits all, and that's it. I think TEER is very strong. For most of these functional patients, TEER will be the gold standard. But I can see a toolbox approach. I can see borderline patients that we are now treating with TEER and compromising with an okay result, like a 2+ MR, for example, because there's nothing to do. All these patients in the yellow zone being shifted towards a replacement therapy, provided that replacement can be safe, can be reproducible, can be broadly applicable, can be reliable. And I see that happening sometime in the next few years when 2 or 3 of these devices are available.
Good. George? Okay. Any comments from Theo?
Very quick one. Congrats again, Vlasi. I have no, specific comments other than a question. Of course, my heart sinks to the bottom when you said that there are 3 new technologies coming up now, approved, got CME mark or FDA, and you particularly mentioned that there's light in the tunnel. I see darkness in the tunnel for us, but all the best for the patient. So congratulations on your amazing work. There seems to be a attempted classification of MAC coming out, emerging in our conferences in the last year or so. Now, could you specify a bit which configuration of MAC or distribution of calcium is optimal for this disease? And how should I, coordinate best care with my cardiologist when it comes to valve replacement in MAC, surgical or transcatheter?
So that's a very, very interesting question. First of all, let me see. I don't see darkness in the tunnel for surgery. Surgery is gold standard for repair. I mean, you're an expert surgeon, you know it very well. I don't think this will go away because none of these therapies are actually aiming to the population of gold standard, minimal invasive mitral surgery that you guys are performing. But we're looking into the non-operable population, high risk or functional patients that are now no longer a target for surgery. When it comes to MAC, MAC is really there's MAC and there's MAC. So you can have mild MAC, moderate MAC, severe MAC. For example, the Atlas trial took a cutoff of 1,000 cubic millimeters of MAC volume, the CC, on the CT as a cutoff for severe MAC, and we've seen anything from 1,000 to 25,000. So you can see MAC 360 degrees. You can see MAC protruding in the LV, MAC protruding, as the one case I show, inside the mitral plane. And clearly, depending on what device you're going to use, you will have different cutoffs and different definitions of MAC. For example, the MAC score that Maya Guerrero proposed for a balloon expandable valve in MAC is a totally different classification to the one that we use for the Alta valve. In the Alta valve, you don't care really about the MAC score. All you care is about anatomic suitability, and you just care about a lot of protrusion of MAC. You don't want big spikes protruding. Then recently we incorporated the balloon valvuloplasty that actually works very well, as you saw in that example, and maybe that's no longer an exclusion as well. But MAC is a problem. The more MAC you get, I think it signifies also a very complex pathophysiology phenotype. Most of these patients with a lot of MAC have got lots of comorbidities and they're sicker. And I think the outcomes are dictated because of that more than the device that you're going to use or the method that you're going to use.
Thank you, Vlasi. Thanks for specifying.
Okay, so thank you, Vlasi. So we have to go proceed.
Okay.